Welcome back, our fans. What you can do. A regular dental check. Up is an excellent opportunity for a head and neck examination. Examine your patients using the head and neck examination. Obtain a history of their alcohol and tobacco use. Inform your patients of the association between tobacco use, alcohol use, and oral cancer. Follow up to make sure a definitive diagnosis is obtained on any possible signs/symptoms of oral cancer. Oral cancer is 6th most common cancers worldwide. Early detection and diagnosis of early oral cancer lesions. 1. Represents a real challenge for health professionals and offers the best chance for cure. 2. Speeds proceeding to treatment, so can improve the prognosis. Prevention. Early diagnosis and the care of patient post-treatment for cancer. Oral cancer has diverse cellular origins that include A. Oral squamous cell carcinoma, OSCC. 90%. Approximately 70% of OSCC develop in the flora of the mouth. B. Others. 10. L. verrucous carcinomas. 2. Sarcomas of the soft tissue. 3. Adenocarcinomas, salivary glands. 4. Malignant melanomas. 5. Lymphomas. 6. Malignant lesions of the jaw. 7. Paraneoplastic syndromes. 8. Head and neck malignant disease and AIDS. 9. Metastatic cancers. Tobacco smoking and alcohol consumption. Tobacco smoking is considered the main risk factor for oral cancer. Although the association between cigarette use and oral carcinoma has been firmly established, other forms of tobacco use, cigars, pipes, and smokeless preparations, have been associated with oral cancers. Tobacco contains potent carcinogens, including nitrosamines and polycyclic aromatic hydrocarbons. Tobacco smoke contains carbon monoxide, thiocyanate, hydrogen cyanide, and nicotine. All forms of alcohol have been implicated as risk factor of oral cancer. The combined and synergistic effect of tobacco and alcohol were illustrated risk factors. 2. Smokeless tobacco products, tobacco, betel nut and snuff. Chewing. Nitrosamines, N-nitrosamine is the most potent non-combustible product. 3. Reverse smoking. In some countries, members of low socioeconomic groups smoke rolled tobacco leaves or small cigars with the lit end placed in the mouth, termed reverse smoking. In these areas the incidence of palatal carcinoma is high. 4. UV. Sun exposure, fair skin and a tendency to bum, pipe smoking, and alcohol are identified risk factors of lip cancer. 5. It is established that human papillomavirus, HPV, play a role in oropharynx cancer but require further evidence for oral cancer. Herpes simplex virus, HSV1 and HSV2, may modify the risk of oral cancer. 6. Immunocompromised. Patients undergoing allogenic stem cell transplantation are at high risk of developing secondary neoplasms including oral cancer. OSCC is documented after an extended period of immunosuppression post-transplantation. 7. Nutritional factors. It is assumed that vitamin A may play a role in oral cancer. 8. A number of genetic conditions. Fanconi's anemia. Plummer-Vinson syndrome. Dyskeratosis congenital. 9. Chronic inflammation and trauma. Although not evidenced, chronic inflammation, candidiasis, syphilis, is blamed to play a role in oral cancer. In addition, other possible carcinogens includes chronic trauma as denture irritation, irregular teeth or restorations and chronic cheek biting habits. A conventional oral examination. 2. Adjunctive techniques. Vital stains. Exfoliative cytology. Brush biopsy. Fine needle aspiration biopsy. Biopsy. Light-based detection system, reflective tissue fluorescence. Tumor markers. Radiographic assessment include an X-ray, MRI, CT scan or PET scan. Cancer detection and screening. Diagnosing oral cancer is comprised of 2 basic steps. A conventional oral examination. It is simple, cost-free, non-invasive. Inspection. The whole oral mucosa should be examined. Palpation is of particular relevance with bulky, firm lesions being of much higher concern than a soft lesion with identical texture to the adjacent tissues plus LNs. Particular attention should be given to high incidence / risk sites for OSCC PML clinical forms of OSCC. 1. Oral cavity tongue most frequently occur on posterior, lateral border and ventral surfaces. Floor of the mouth, second most common site. Retromolar area. Less common sites. Gingiva. Buccal. Mucosa. Labial mucosa, hard palate. 2. In addition. Vermilion border. Striking predilection for the lower lip, usually in light-skinned individuals with a long history of actinic damage. Oropharynx. Clinical forms of oral cancer. 1. Indurated swelling / ulcer, i.e. firm infiltration beneath the mucosa. 2. Granular verrucous ulcer with fissuring or raised exophytic margins. 3. Bloody crusted ulcer. 4. White, red or mixed white and red lesion. 5. Swelling sometimes with abnormal supplying blood vessels. 6. Non-healing extraction socket. 7. Lesion fixed to deeper tissues or to overlying skin or mucosa. 8. Cervical lymph node enlargement, especially if there is hardness in a lymph node or fixation. Oral cancer must be suspected especially when there is a single oral lesion persisting for more than 3 weeks. Classic features of oral malignancy include ulceration, nodularity, induration and fixation. These features are features of advanced disease, not early-stage disease. Potentially malignant lesions / disorders, PML / D. OSCC may be preceded by clinically evident lesions. Termed premalignant, precancerous or potentially malignant lesions. A precancerous lesion is a morphologically altered tissue in which oral cancer is more likely to occur than in its apparently normal counterpart. For example, leukoplakia, erythroplakia, a precancerous condition, is a generalized state associated with a significantly increased risk of cancer, for example, submucous fibrosis, lichen planus, etc. Thanks for watching. Support us by likes and subscribes.